Well, I want to introduce myself. Some of you know me. I'm Dr. Carrie Mendoza. I am the Director of FAIR in Medicine, and we are part of the FAIR family. FAIR in Medicine, works to advance FAIR's mission, and specifically within healthcare, we're working to have conversations related to important topics, hold up the scientific method and research, and just bring people together to have these important conversations. So thank you for everyone attending today for our webinar about gender dysphoria and its impact on clinical care. I want to introduce our host and senior fellow, Zander Keig, and our panelist, Dr. Lisa Littman, a physician scientist researching gender dysphoria and detransition, as well as Stella O'Malley, a psychotherapist and the executive director of GenSpect, an international advocacy group providing great resources and education on the best practices for gender dysphoria. And then Teva Johnstone, so glad she's here. She's a psychotherapist and children's mental health consultant. And so with those introductions, I'm gonna pass it over to Zander.
Thank you, Dr. Mendoza. Hello, everybody. Thank you for joining us tonight. So glad that you're able to be with us. I'm going to begin by actually asking each of the panelists a few questions that are specific to their area of expertise before I ask more general questions. So I'm going to go ahead and get started with Dr. Littman. Dr. Littman, can you give us a little bit more information on what is rapid onset gender dysphoria? And have your findings been supported by others? What have critics said about it? And a second question would be, can you say more about social contagion as it relates to young people who are presenting to gender clinics worldwide? But let's start with the ROGD, rapid onset gender dysphoria.
Right, so thank you. Rapid onset gender dysphoria is a term that I created to describe a presentation where adolescents and young adults become gender dysphoric and trans-identified in the absence of having symptoms or gender distress expressed during their childhood before puberty. So ROGD is that term for the presentation, but there are also hypotheses around it that came from my first research study of parent reports. So that research study was conducted and published in 2018, and several hypotheses were developed from this, primarily that this appears to be a new presentation or cohort, and the other hypotheses are that psychosocial factors such as social influence like social contagion or peer contagion, mental health conditions, maladaptive coping mechanisms, internalized homophobia could contribute to the development of gender dysphoria in some individuals. So shortly after publication, there were several things that gave support to the research. First, several clinicians wrote letters to the editor in medical journals describing that what was described in my research was something they were seeing in their own patients. And these are clinicians who work with gender dysphoric youth. Then detransitioners, individuals who experienced gender dysphoria, transitioned and then detransitioned, expressed that the research matched their personal experiences with gender dysphoria. And then I conducted a second study with detransitioners addressing the criticism that the first study was collecting data from parents, and this one collected study specifically from individuals who had detransitioned, speaking about their own experiences. Very briefly, many of the critics have taken issue with the methods used in my study, such as parent report, targeted recruitment, anonymous studies, but those are the same methods used in other studies, including the studies that support gender transition. So sometimes it seems a little disingenuous because you can't say that these methods are unacceptable in my study, but then completely completely fine in studies that support the desired narrative. So that's not scientific. And then just finally, social contagion is the spread of behaviors and emotions through a population. And this is something that if you were to study it, you would look for clusters, but it's been seen in for happiness, depression, eating disorders, suicides. So human beings influence each other, and that's just a specific type of spread. And this is something that could be a possibility, could be something to explain some of the rapid rise that we've seen worldwide about gender dysphoric teenagers presenting to clinics.
Thank you very much. There are two things I want to say. One is when you mentioned something about the similar methodology, but the disingenuousness of challenging the methodology that you used, but not in other studies. I'm wondering if that's because it's being challenged. Is it being challenged in scientific, places, or is it in the media? Is it right? Because in the media, people don't know about methodology. So it's easy to challenge it because people aren't going to go, but wait a minute, you use that same methodology, right?
Right. And actually, it's fascinating because it appears in both. Yes, it's appearing in the media and in the lay public, but I do think that there are researchers and clinicians that are very aligned to a particular viewpoint. And so there's a little bit of a disconnect in that, it's part of basic confirmation bias, that things that you want to believe, you're willing to accept less evidence. And it's common to think that what supports your viewpoint is of higher quality than others. But that's actually why I wrote a response about the methodologies, in which I put side by side the articles, that my article versus other articles that support the gender affirming model of care, and just went back and forth like, okay, this is what both of them are about parent report. Here's where both sides use anonymous studies. Yeah. So, yeah.
Well, I mean, for people who don't know me in the audience, I'm a licensed clinical social worker. I'm a trans man. I'm a WPATH member. I'm a faculty member with their Global Education Institute. So I've been doing trainings. I've worked as a gender therapist. I've done a lot of things around trans social care, primarily as a social worker. And I remember when your article first came out about rapid onset gender dysphoria. And if I recall correctly, the first criticism that I saw go pretty wide was, that's not a diagnosis. Do you? And I thought
do
that was
remember
an
that.
Interesting response. Yeah.
Oh, it's incredible, because how could a first report of a phenomenon already be a diagnosis? So I do think that there's a lot of grasping for reasons to dismiss the research, and I think that's one of them.
It was a diagnosis.
I never said it was a diagnosis, but I've had to say so many times that it's not a diagnosis.
Yeah.
Or not at this point. Yeah. I mean, it takes time to, Yeah,
right. It takes time to develop that, but it's putting forward a phenomenon that you had observed. Yeah.
Yes.
Okay. Thank you so much, Dr. Littman. We'll get you back in when I open up the questions more generally. I'm going to go now to Teva. Teva, according to recent research, there seems to be an overrepresentation of autistic youth who are presenting for medical treatment at gender clinics. And I'm wondering, why do you think that might be? And are you seeing this reflected in your practice working with parents of children who have autism?
Yes. So autistic people have like a different understanding of social norms. I like to describe it as like, don't know, don't care. So like, even if they do know, they don't really assign as much importance to it, or they truly have trouble like kind of understanding social norms, if you will. So that kind of makes for a perfect scenario of wanting and feeling outside of typical gender binaries. And there are some other conditions as well, like sensory processing differences, interoceptive differences, where it's like sort of feeling, not feeling totally in touch with the physical body, like not always getting the sensations of hunger and thirst. And there's a lot of cognitive inflexibility as well. So some of the youth who are spending a lot of time online, which I think this is connected to Lisa's research, to Dr. Littman's research, is that the trans community is really popular online. It's like an accepting community. And for autistic youth who don't belong socially often, they have trouble making friends. It's kind of like, oh, you know, I feel outside of the gender binary. I'll join this group and they're accepting of me as I am, which is wonderful. But because of the cognitive traits of inflexibility and kind of hyper focus and getting sort of stuck on ideas sometimes, and there's also a lot of persistence. So like an autistic child, they're known to be very persistent and demanding of their parents of certain things. And so it's like, once they get it in their mind that they are trans and they want to transition, it's going to be very difficult for parents to not go down that affirming route, especially when all of their culture is telling them that that's the right, respectful thing to do. So I think that might have something to do with ending up at the gender clinic. And then in my work, I see parents and they are contacting me very concerned. I'm seeing just a huge spike in parents saying, I need help. My child is declaring that they're trans. I have no idea what to do. This just came out of nowhere. And I've been practicing for 8 years, and I am just now seeing this in my work.
Interesting.
Yeah.
Well, this concept of don't know, don't care, as soon as I heard you say it, I thought, well, that was probably my attitude too as a young person. I was very rebellious and countercultural, gender nonconforming. But you're saying like there's a difference between your standard, you know, sort of rebellious, anti-authority, gender nonconforming kid, that autism really does have, it has an additional set of particular characteristics that could be leading to this overrepresentation. I mean, it's hard to say overrepresentation. I'm not exactly sure what that means. Maybe it's just disproportionate. That's probably what this research is showing. Yeah.
Disproportionate. I think so, Zander. Autistic people, many autistic people self-report that they don't feel like a man or a woman. And I don't know, see, in my mind, a man and a woman, it's boundless. There's not one way to be a man or a woman, but there's a theory that some autistic people with the more like concrete thinking think that there's like one way to be a woman and one way to be a man. And if I don't fit in either of those binaries, I must be something else. And the language right now is, you must be trans.
Yeah, so it's not just that you're gender nonconforming, it's something else. Wow, that's really interesting.
Well, I think
as soon as I heard you say, I don't know, I don't think like a man, or it's sort of like, or a woman, it's sort of like, I don't even know what that means either. You know?
I don't either. And also, Zander, like right now, the trans umbrella has sort of taken typical gender nonconformity under its wing, if you will. And so it's like everything is being called trans now that doesn't fit this 1950s stereotype. So typical gender nonconformity, it's now being thought of as trans in many communities.
Well, I think I've actually read redefined, people have redefined transgender, right, as a term. And I think it is as simple as gender nonconforming. And you said something about the 50s version of gender. Something that it made me think of immediately is maybe that's why those of us who are transsexuals are being sort of pushed out by this, you know, sort of a critical mass of people that are more gender nonconforming that are coming in under the umbrella, and the umbrella can't hold us. Like where some of us are out getting wet, and it's because there's not enough room, because it's so broad now that people like that, me and my community, the transsexual community, it's almost as if we're no longer welcome in some transgender spaces. It's quite fascinating.
Yeah.
Well, I appreciate your points on this and the work that you're doing. Of course, you'll be brought in when I start asking the more general questions, but I wanted to really understand, you know, what's been going on for you in your practice. Hello, Stella. So glad to have you back. You were on our last panel discussing these issues. So I wanted to talk to you a little bit about GenSpect. So that's the organization that you're the executive director of. And in July, you published an open letter to the American Academy of Pediatrics. Now, of course, you're a UK-based organization, so that's interesting in and of itself, right? You're writing a letter to the American Academy of Pediatrics. So I'm curious, what prompted that? And can you give us an update on what's transpired since then? And then I'd also like you to mention, I can repeat the second question if you'd like, which is WPATH recently released their standards of care. It's version 8. It came out just last month. And I'd say it's been considerably controversial since its debut. What has been GenSpect's response to these new standards of care?
Yeah, there's been a lot going on. We're an international organization. I'm in Ireland. A lot of people say it's UK, but it's Ireland. But
Yes.
why we were interested in the AAP was because I suppose in many ways this new looking at gender has been centered in the US. And so we're very interested in what goes on in the US because a lot of, what happens in the US spreads over and vice versa. There is, back and forth happens. But in what happened during the year with the AAP was very interesting. They have a kind of a protocol where pediatricians can ask questions in a forum, and it's a well-established protocol. And 5 pediatricians asked for a very, very kind of what I would consider appropriate question, which was, in view of the sharp rises of the number of young people presenting with gender dysphoria, and in view of the major about turns that certain countries have taken in their way of treating gender dysphoria, for example, Sweden and Finland and France, less so, but a little bit, in England, have all reviewed the way they treat young children with gender dysphoria, and they've moved away from medication, and instead they're more in favor of psychotherapy as a least invasive first, better approach. And what the 5 pediatricians asked was, could we have a systematic evaluation of the evidence for the affirmative care model? So to me, that is really pretty standard. And what happened was really quite extraordinary. The AAP chose to use a kind of a very unknown bylaw that they'd never used before to kind of remove this resolution, which was resolution 27. This was the kind of the controversial resolution, which was simply asking for an evaluation of the evidence. And that kind of sparked people like GenSpect to say, why did you do that? Why did you remove that? That doesn't seem kosher. It seems very inappropriate. And so we wrote this open letter saying, why did you remove this? It felt like a very appropriate question because gender is very high in the news. And these were 5 pediatricians asking. And from that, a huge amount of media took up on it. An awful lot of people, it kind of triggered a lot of people of, yeah, why can't we ask about that? Why can't we ask about that? And ultimately there was a conference last weekend, was it last weekend or the weekend before? And a lot of parents descended on Anaheim, which is where the conference was, to kind of have a silent protest. And you could almost see that how the open letter started questions, and more questions happened, more media happened, more questions happened. I'm sure the AAP, how do we get rid of this? Why didn't we just let little resolution 27 pass? That's all they needed to say is, we'll look into it, but that didn't happen. And then your second question would be WPATH. They are the World Professional Association for Transgender Health. And they issued their 8 standards of care. So since 1979, every so often they issue a standards of care, which is their self-identified standards of care, because standards of care is not a moniker you can call anything a standards of care. It does have to go through a certain level of criteria, and theirs don't quite meet it, but they call it a standards of care. And it's clinical guidelines. It's kind of guidelines for anybody who's working in the area. And they were very unusual goings on in the release of this. So when it was released, they had, for example, minimum age requirements for mastectomies and minimum age requirements for vaginoplasty and for cross-sex hormones, which most people would consider would be fairly standard. However, the minimum ages were young. It started at 14, 15, 16, 17. These were the ages. And then within a day, they took the extraordinary decision, having spent maybe 3 years or certainly many years writing this with an awful lot of input from an awful lot of people. And then within a day, you release it, you're ready, it's your fabulous document. You spent all this time, 120 signatures or 119 signatures on it. And within a day, they took out all the minimum age requirements and said, this is a correction. It felt like an extraordinary, I don't think that I would call that a correction. I would call that an ideological change of heart. And it happened very quickly. And I thought, well, obviously the 119 signatories couldn't have signed off within a day, because I know what it's like to try and get 5 signatures in a day. There's no way that that was happened. So that was extraordinary. And then they also did a few other things. They decided in their guidelines to insert a chapter on eunuchs. And many of us would consider eunuchs as something from past history. And it's a very sad history. Like eunuchs have had a sad life and is sad. They've brought it in as a new identity, which feels very incongruous. And at the same time, they decided not, they had in their draft proposal last winter, they had a chapter on ethics. But in their actual release of the actual standards of care, they took out the chapter on ethics, which made me and many people at GenSpec think this is an activist-driven standards of care. This is no longer a clinician's standards of care, because clinicians would insist on a chapter on ethics would get in. And it got taken out, and the chapter on eunuchs got put in. To me, that kind of it seals the deal. This is an activist-driven organization and an activist-driven document.
Well, those are very, well, I mean, just so interesting points. I mean, I had mentioned previously that I am a member of WPATH. I'm faculty with the Global Education Institute. I'm also a member of the ethics committee, and I was on the group that was writing that ethics chapter. So I can't divulge anything more than that, of course, but yeah. So two things came up that I wanted to probe a little further into, which is now in these countries around in Europe. So its last course of treatment will be to put children on what they call puberty suppressant or puberty blocker medications. And is it also true that part of that will be, if they do go on those medications, they'll be enrolled into some sort of long-term study to actually look at, because there aren't any of those studies available that are focused on children taking the hormones or the medications for that specific purpose. We have precocious puberty studies, but not for the purpose of suppressing puberty because of a gender identity issue.
Yeah, it's a very under-researched cohort. These are children. Yeah. And you know, pretty much all the research based upon the thousands and thousands of children who are put on puberty blockers is based upon effectively a study of 70 children in Holland, in the Netherlands. And while those 70 children, they haven't been followed up in the long term. So, you know, a year afterwards, they might have been happy, and they might have been happy when they're 19, but we don't know what happened to them when they were 27 and 37. So that in itself is a major, major gap in the research. And what's now happening is many, you know, for example, Sweden were the pioneers for transgender healthcare, pioneers for pediatric transition. They've pulled back so that what they're doing is favoring psychotherapy, and any child who is put on puberty blockers is under strict clinical trials. As in, if we're going to do it, we're going to make sure we follow this, and we're going to do it properly. Finland are favoring psychotherapy. I just think it makes intuitive sense. Of course, you do the least invasive first approach with children. Of course, you don't medicate them. You know what I mean? If at all possible, because we don't actually know what's the long-term impact of not going through. I do want to say this: when you suppress puberty, you're suppressing the adolescent life. So if you're 14 and you're on puberty, everybody else is fancying everybody. Everybody else is talking about everything that's going on. And I know it's hard to be an adolescent, but you're so out of sync because you're your genitals aren't developing, your sexual impulses aren't developing, you're not fancying anybody, it's going to make these children feel very, very, very different because they're not going through that long process between around about 10, when all children are asexual, to around about 20, and all of us are sexual. That is a long process where all sorts of things are going on in our minds. And we actually go from being very self-absorbed because we're not sexual to being outward, we're looking at everybody else looking for a mate. All of that isn't happening to somebody whose puberty is suppressed. We have no idea what's the psychological implications of that. It's huge as a concept.
Well, and I would imagine, I'm not a physician, so I can't speak about it, but my thoughts are that it's also going to suppress or delay or block other types of development, right? Other physiological, cognitive, social, right?
Mm-hmm.
All kinds of things are going to be blocked, and that doesn't sound good. At least not if it's longer than, a few months, or, I mean, like if it's, but not if it's somebody's on these blockers for 2, 3, 4 years. I think that's when I could see it being very detrimental overall.
Especially for autistic youth and ADHD youth, they cannot afford to not have the neurological development that happens in puberty. They are already so compromised in the areas of executive functioning and flexibility, and they need to develop. And so opting out of puberty it's not an option if we want the best outcomes for these kids.
Yeah,
there's also a big concern about whether or not it is interfering with desistance. So the majority of young people who feel gender dysphoric, when they go through puberty, these feelings will resolve, and they will often grow up to be lesbian, gay, or bisexual adults. What has been studied in terms of events that are very instrumental in terms of desisting or persisting is beginning to understand your sexuality. And so there has been concerns raised that especially for young people who are gay, lesbian, or bisexual, that it will interfere with their ability to understand their own sexuality in that way, and basically veers them onto another track.
Wow. Yeah. Wow. Interesting. Stella, one more thing for you, because if I'm curious, you had mentioned that the WPATH standards of care don't seem to, and I'm wondering if it's just this latest version, don't seem to actually meet criteria to be a standard of care. And I'm wondering, is there some body somewhere, some association, some entity somewhere that people can say, these are not standards of care, and have them reviewed? Is that something you think people are looking into? Because they have changed. And I'm wondering, were standards of care 7 more actually standards of care, and 8 somehow took a turn?
I'm very keen to hear what Lisa will say. I'll start her off and then Lisa can take over because she's the research expert here. But I do know there's a brilliant paper, and I'll put it in the chat, which effectively goes through what are the criteria to reach the kind of level of being a standards of care. It has to do this, it has to do that, it has to do the other. It doesn't do that. And standards of care 7 didn't do it, and standards of care 8 didn't do it. Wow. And so, we could release a standards of care tonight, and we could say, here you go. You can call yourself a standards of care, but to be an actual, what's the word, an accredited standards of care, or a recognized standards of care, you have to have certain criteria, and it doesn't. I think you probably know more. I'll put it in the chat, but I think you probably know more, Lisa, about this.
Yeah, so SOC 7 was even less than SOC 8 in terms of evidence used, in terms of systematic reviews. Now, SOC 8 has very few systematic reviews. They really should have been more, but they build this as the first evidence-based. And if you look at SOC 7, they basically had on the first page something to the effect that there were significant changes made from 7 from 6 that were based on, I think, changing expectations and clinical experience. And what is missing from that is evidence. So there was a huge departure from 6 to 7, and this was in 2012. And it was not based on evidence. It was really based on other things.
Well, there's two things that brings up for me, which is one, could they just call it something else, but is using the phrase standards of care important somehow, maybe for insurance company application? Like, could it just be called guidelines? And within the social work profession, we talk about there's evidence-based practice, but there's also practice-based evidence. And I'm wondering if they're giving a bit more, they're leaning more on one than the other in trying to do the more psychosocial focus.
Yeah, so as Stella said, it would be more appropriate to call them guidelines. So I don't think they ever were meeting the criteria for standards of care.
Interesting. But I don't feel like I don't believe I've ever heard anybody call that into question. Like, in all these years that I've been a clinician transitioning, I don't think I've ever heard anybody say that. I didn't even know until recently that standards of care was something that had strict criteria attached to it. So that's interesting. Okay, well, thank you. Oh, go ahead.
There's a nice little paper I've put in the chat there, and it gives a nice kind of, well, for the studious among us, a kind of what are clinical guidelines, what are standards of care, what are the criteria. They do mean something, these phrases, yeah. And you can't just use them flippantly. Well, it turns out you can.
Yes, yes. Thank you for that, Stella. I appreciate it. And thank you all three of you for answering those more specific questions. Let me move into some more general questions, and any of you now can answer these questions. I'm curious, in your opinion, do you think that gender identity theory or queer theory at all is influencing the way healthcare services are being provided now, and sort of the lens in which even the standards of care are being were drafted and are being applied? Who'd like to go first?
Maybe I'll go first, and other people might come in after. I think they are. I think an awful lot of young people are unknowingly, they don't know that they're very influenced by queer theory and gender identity theory, and they're often an amalgamation of these two theories. And funny enough, these two theories kind of contradict each other, because queer theory means you queer everything up. So, you can identify any way you want, and if you want to medicate, you medicate. Well, gender identity theory has a different theory, which is saying if you have a different identity, you need to medicate, and it's kind of an essential. And yet that's why an awful lot of teenagers, they almost say contradictory things. And I think they are being influenced, but they don't actually know they're being influenced, which you could say about every single thing we do. You know what I mean? Why do I want that white top, and why don't I want the blue thing? We are often very, very influenced by our social context. But yeah, I think they're huge influencing factors. What's very interesting about this new cohort that Lisa has so well studied is that this really comes from the ivory towers of academia. Most movements are kind of grassroots from the people, and it goes up. Well, this is very much from the ivory towers and has gone down, which is part of that upending. Everything about this is it's the other way around. It's very Alice in Wonderland. It's very kind of, you have to take a beat and understand what's going on. And that to me is one of them, that it's actually very academically driven as opposed to anything else.
Well, I was going to say, I first learned about queer theory in college in the 90s. And of course, it was Michel Foucault, and this idea of queer theory was to deconstruct everything, right? To just pull everything apart and look at all of its little pieces, everything in society, everything within the family, everything within our institutions. And so this idea of queering things is really just to, tear it apart and look at it and maybe put it back together in some sort of, disfigured way. Gender identity theory is not something I've ever studied. I was in women's studies courses, in college, and we had, the theories around gender. But once I started to transition, it was very obvious to me that what I was learning in the classroom and what I was experiencing in real life didn't align. They didn't align at all. So Lisa, what do you think?
You know, it's very interesting to me that this and these beliefs around gender identity and queer theory have permeated not just society but medical, professional organizations. So this idea of, there are different beliefs about gender identity, and one is that everyone has one. It is something that expresses your true self like a soul, and it can either match or not match your physical body. And if it doesn't match, there's only one reason for it, and there's only one way to, only one treatment, which is transition. And so there's this other perspective, a more developmental, holistic, whole person perspective, where this concept of gender identity, we should really be talking about sex and physical body and what people think about stereotypes and how they participate. So that in this developmental approach, gender dysphoria can be caused by a lot of different things. And that, person may not have a gender identity. They might say, I'm female or I'm male, and that's the end of the story. But this other approach, which I think has been really steamrolled, in current society, is really takes this broader non-queer, academic queer theory of there are things that are objective, and there are developmental issues and a lot of contributors to gender dysphoria and a lot of different pathways. So that, that's what I think about the topic of gender identity and academic queer theory.
Teva, do you have anything to add to that?
Oh yeah, I could talk about this all day, but as far as like clinically, I think that therapists they're like unaware of what gender identity theory is, what queer theory is. They don't know that they're like philosophical belief systems, almost like a quasi-religious framework of having this soul that's been born in the wrong body, and the soul was male or female, but I accidentally have this other body. And it's just like, therapists they're not questioning any of that. And then those of us who do, we're looked at as like bigots for mentioning the body, the biology, talking about sex, male, female. And social workers, Zander, we're trained biopsychosocial. Some of us also spiritual. I went to a faith school, but we're just like throwing all of that away and just accepting at face value. This child says that they're a boy. Okay, let's start the affirmative transition process. And we're not investigating the whole picture like we have been trained to do. So to me, it really feels like an abandonment of like our training and our ethics.
I definitely agree. Yeah, I can remember when I first started transition, people would say to me, how do you identify? What's your identity? And I would always look at them and say, I don't know what you mean. Like, I didn't understand the question. And I thought, well, maybe it's me. Like, I should do some reflection, and figure out like, how do I ID? And I just really couldn't come up with anything. And then somebody asked me a question once. They said, or as I was doing this process, they said, well, did you identify as a lesbian before your transition? And I'm like, no. And they go, but I thought you were a lesbian. I go, yeah, I was a lesbian, but I didn't identify as a lesbian. Like, I really do see that as a difference. And another thing about the biopsychosocial spiritual assessment, I'm with you right there. As a seminary graduate and a social worker, that's important to me. When I hear people pushing back on, being trans isn't a mental illness. Trans people don't need psychotherapy. I usually say something like, well, we should always start out with a comprehensive biopsychosocial assessment in order to find out what their support system is, whether they have stability in their job, their housing, their income, their health, and other ways. And from there, you might learn that they could benefit from some short-term psychotherapy. That's how I tend to phrase it. And I'm glad to see, I do believe the new adolescent chapter does recommend, if not sort of put in there as a requirement, that the adolescents before starting any hormones do have a comprehensive biopsychosocial assessment. conducted. And so I'm hopeful that that's happening. But what I've learned over the course of being a social worker and being married to a marriage and family therapist and working with mental health counselors and psychologists is that I think social workers are really the only clinical professionals that are trained in how to do a comprehensive biopsychosocial assessment in the way that we do it, because we tend to be in a lot of settings where we need to know all that information. So if you say to a marriage and family therapist or mental health counselor or psychologist, you need to do a comprehensive biopsychosocial assessment, they might not know how to do that. So I think we need to educate people on what a comprehensive biopsychosocial assessment is, which is hard to say over and over again. That's why I'm getting tongue-tied. Yeah, so great. Let me move on. So the topic about detransition, we hear a lot about. We have groups of people coming together and creating videos. They're going on talk shows. There's studies coming out. And so I'm curious what you all think around, with the detransition population in particular, is do you think in any way that uncertainty and doubt in the early stages of them going through actually a medical transition, doing the hormones, maybe having surgeries, has influenced their detransition, that they're maybe not getting advised or referred to psychotherapists, and so they're not able to process any uncertainty or doubt, which I got to tell you, I had that, and I have it all the way through. It comes up, I'm human. So I'm wondering what you all think about that.
Yeah, and so there are several different pathways that I have heard from detransitioners. One is that if they express uncertainty or doubt, this is very frowned upon in the communities that they're in and on social media. So they are often told directly to work through it and ignore that. You know, that's just, you know, that's not relevant. And I think that does a disservice to anybody when you're telling them, don't pay attention to your feelings. The other thing is that many of the detransitioners felt that this was the only thing that was going to help them. And they may not have had doubts going in because this is the information that they have been fed. And many of them will start transition and become very happy and almost euphoric. And then it's only when they realize that this medical intervention did not fix the problems and did not improve their lives the way that they felt that it should have, that they come to kind of put the whole picture together. You know, and one thing that keeps coming up is misdiagnosis. Like, were diagnoses of mental health disorders, psychiatric problems, trauma, all of these things missed because as soon as they said the words transgender transition, everybody jumped on the track and just said, here we go, we've got one solution. So yeah, so a lot of different ways to go through either uncertainties or certainties and getting to detransition.
Thanks for that, Lisa. I mean, I've got to think that there may be some out there, but my impression and my hope is that this is unfortunate what's happening, but my hope is that it's happening because people think they're doing the right thing, that clinicians think, right? They've been so persuaded towards one point of view and dissuaded from any others, as Teva was saying, that I think they think this is what I'm supposed to do, and if I don't do this, I'm gonna get in trouble, because that is happening to people. But the consequences of it can be quite devastating for people, as I've heard them say. Stella, what do you think about?
I think you know, the thing about detransitioning is, more than anything, is that these are where we should be learning. We should be most interested in the detransition experience. That's where we should really sit very still and really listen very deeply. And it's extraordinary indictment of this phenomenon that isn't happening, that they aren't being welcomed in and, you know, really kind of brought into everybody's kind of hearts and saying, what happened? Let's discuss it. Let's figure out what went on. Because we humans, we make mistakes. Of course we do, in healthcare all the time. And, you know, honestly, we have to be forgiven because we are human, so we do make mistakes. We can't quite be forgiven if we suppress the mistakes and pretend they didn't happen and dismiss and alienate the people who are saying, I think there was a mistake made and I think I'm going to regret this for the rest of my life. in GenSpec, we have this program. We launched it in June called Beyond Transition. And what we're doing is we're providing low cost and no cost counseling and other things like job skills and rebuild your life package and a therapeutic support group and one-to-one counseling, all for people who are what we call beyond transition. So some of those are detransitioners, many of them are detransitioners. Wow. Some of those are people who've been impacted by gender issues and maybe they feel they can't revert back to, you know, their biological sex. I think I saw Scott Nugent there in the chat, and you know, he's such a lovely man who transitioned, and it's been very, very difficult, you know what I mean, for a range of different reasons. And so the idea with the Beyond Transition program is to help people who've been impacted by this. And hopefully we hope to have a lot of data around this and to kind of get some information around this cohort as it grows. We're already helping nearly 70, over 65 people are already gone through this program or going through our program. And what we're trying to do is help them and figure out what's going on. What are the golden threads? What do we need to learn? Now, Lisa Littman's study was amazing. That was 100 detransitioners. It was the first bit of meaty data that people could look at and say, whoa, okay. Because, for example, I think I'm right in saying 76% of them didn't go back to the clinic to tell them that they had detransitioned. Now, that's a really important piece of information. They don't want to go back. They don't, of course they don't want to. And we're noticing an awful lot of things with this cohort. So there will be information one day, but right now I think they should be the most listened to rather than the most dismissed.
Absolutely. You know, I remember when the detransition people, it was first starting to hit the community and people were talking about it. And I said to some of my friends within sort of the trans medical space, you know, we should be talking to them. We should be listening to them. There were other people that were saying that too within WPATH, as a matter of fact. And I remember somebody told me, you know, well, they're just the outliers. And I kind of looked at the person, I said, we're outliers, like trans people are outliers. Like if we say we're dismissing those outliers, what's to stop others from dismissing us as outliers? And they just sort of looked at me like they hadn't thought of that before. And I wanted to also bring, Lisa, you might be already familiar, maybe all of you are familiar with Kinnan Ross McKinnon, a trans man professor at a university in Canada who's also studying detransitioners. And one of the things that he's finding in his studies, which I find really troubling, is that the doctors, the endocrinologists, or the therapists that these individuals were going to before they stopped taking hormones or going to therapy, that most of them have reported that none of those providers are following up with them. No, like 3 months out, like, hey, you haven't filled your prescription, or I haven't seen you in a while. No 1 year out, no follow-up from any provider, you know, or most of the providers. I find that really troubling. And so I'm hoping that people can, you know, that shows up in research. Like people, doctors and doctors' offices need to get case managers and follow up with those patients.
Right, and not just follow up, but I think from what I heard from my data, that individuals were embarrassed to go back. They were also concerned that the doctor was going to pressure them to go back on hormones, or that the doctor wouldn't want to hear that they detransitioned because they felt that their provider was so ideologically aligned. And I think there's a real opportunity for educating clinicians to say that when they start transition, to at least try to express to the patients that they care what happens, no matter what their outcomes are. That we think this is going to go well, but it doesn't go well for everybody. We want to know because we care about you, and because knowing what happened to you informs us and allows us to know more for the next person who comes to transition.
Yeah. Teva, are you working with, are you familiar with detransition in a clinical sense?
I don't work with detransitioners. I'm familiar with a lot of their stories just from them, you know, being public. But what comes to my mind is that when you make major life decisions and your brain's not fully developed yet, so if you make the decision as a youth, like it makes sense that there's going to be detransitioners, because like what we all have things that we regret doing as adolescents. So to me, it just kind of seems logical that that would happen. So, yeah.
Well, thank you. I want to thank all of you. We're going to be moving now into the Q&A with the audience, so to speak. Hopefully they've been using the Q&A within the platform there in Zoom, and Carrie's going to come back in, Dr. Mendoza, and field us some questions from the audience.
Yeah, thank you. Gosh, it's amazing discussion. I will kick off here really with something that I think just has come up frequently that seems to be people feel a root cause of maybe why this is just so quickly taken hold in institutions is the supposition that, you know, if a child who's gender dysphoric doesn't medically transition, they're going to kill themselves. So the question of suicide, how are the real numbers in suicide related to this phenomenon? I feel, I know in different forums, folks have spoken about it, but I think it's important to raise again. So, you know, Stella, I know you've spoken eloquently on that. Maybe you could give us just a thumbnail about the data and how one sort of disarms that supposition.
I think when we're talking about suicide, because it's such a awfully tragic event that we have to be very, very careful. We can't, you know, we can't mention it without giving it a serious kind of analysis. And we have to make sure that we're correct, because this is not a subject that we can really afford to be surmising on, nor can it be a subject that we can kind of be half right about. It's too serious. Every single suicide is not only a tragedy, but it's a tragedy for many people around that person who's had such an awful place to go, that's where they ended up. And I followed, you know, what is the kind of the myth around suicidality around gender, and then the actual facts around suicidality and gender. And there is a huge myth grown up. It seems to be traceable back to a kind of a US study that was based upon an online survey. And it talked about people who might have felt suicidal as opposed to who died by suicide. Probably the most factual data that certainly that I know of, and I've very much studied this, is that the GIDS is the Gender Identity Development Service in the UK. They are the largest pediatric gender clinic in the world. And they conducted a kind of, well, they didn't conduct it, but somebody did. I think it was Michael Biggs. And over 10 years, between 2010 and 2020, there was 15,000 children who either were on the waiting list for GIDS, so they weren't getting treatment, or they were being treated in GIDS, which is the gender services in this. So out of 15,000 children, 4 died by suicide. 2 of them were on the waiting list and 2 of them were being treated. So 4 out of 15,000, while it is there are 4 tragedies and 4 terrible events, that's not a statistically significant number. It is not a number that you can kind of, you know, you can't get statistics out of that. You can't draw conclusions out of that sort of number. And so therefore, it kind of gives a lie to everybody who starts talking about stats around suicide. It's like, well, they're the facts, and that's the largest pediatric clinic. Well, you can't really get past that, because they're actually what happened, as opposed to what we think happened, or who thinks that they were suicidal, or suicide attempts. There's a huge difference between suicidal ideation and suicidality. You know, there's a huge difference, and it needs to be really respected, that difference. And then there's another very interesting study from Sweden, where the health authorities, what they did was they just looked at lots of different conditions like substance disorder, substance abuse, and anorexia, and schizophrenia, psychosis, lots of different conditions, gender dysphoria, autism, OCD. They did a graph of which were the most highest over 10 years, who died mostly by suicide. So you could see what are the highly suicidal conditions. And gender dysphoria was on the lower half of that, and it was among anxiety, autism, gender dysphoria. So I'm not saying that these aren't a vulnerable group. They are, but they're no more vulnerable than somebody with autism or anxiety, which is, you know, a fragile group. They need to be given certainly a lot of care, but we need to get it right. If somebody starts talking about suicidality and gender, and if they're in heightened tones and they're quite feverish, they don't know their stuff, and they're causing an awful lot of trouble and distress and harm to people when they're doing it.
Yeah, Lisa, and I don't know if you have, something to add on that front, just in your research, because it seems to be something that's just like replicated. It's almost like a medical contagion through the associations in the school.
Exactly.
Yeah.
Right. And so the research evidence is we don't know yet whether transition increases, decreases, or fails to change the suicide rate. So using this as a way to manipulate or pressure parents or individuals into any pathway. It shouldn't be used to pressure them towards transition. It shouldn't be used to pressure them against transition. We just don't know. This is something that we should always have in our minds, but keep it separate from the transition discussions, because that's where it's more appropriate. It's appropriate to find out about the person, but using it to say, this means you should transition to avoid suicide. That's, it's uncalled for and it's unethical.
Yeah, and I make the analogy of like during the height of the opioid crisis, people would say to me, if you don't write me this prescription for Dilaudid, I'm going to kill myself. And so what that meant was like they have obviously they've got addiction issues, but maladaptive coping. So they went right over to the psychiatric part of the ER. No one wrote them prescription. So again, it's like, yeah, why is it this, seems to be, instead of saying, okay, wow, that's a sign of distress, let's really look into this, not like, let's, emotional hijack. So Teva, what do you think about that, as a therapist, and this meshing of the suicidality claim with, needing to proceed with a certain course of action?
Yeah, I have a few thoughts. One of them is kind of in line with what you were just saying, was that if someone is threatening suicide, if they don't get this thing, they're not in the mental state to make the decision to transition. It's not an ethical place to start from as a clinician, where this person is suicidal, so we're just going to go ahead and make this major irreversible life decision. That's one thought that I have. Another thought is, as clinicians, we know how to work with suicidal youth. Like, we have protocols for suicidal ideation when there's a plan and the means, and we know how to assess, and we know that DBT can be helpful, and we know all these things. And this is the first time in my career that I've heard, if we don't transition a child to live as the opposite sex, they're going to die by suicide. Like, this is brand new into my mental health realm from the last 8 years. Like, we have other ways to work with youth who have suicidal ideation and behavior.
Well, thank you. And that kind of dovetails into several questions in the Q&A, and I'll also ask the panelists to look and scan as well if there's a question that we're not sort of addressing, to, you feel free to speak up. But it relates to several things. Again, we also hear this frequently in the FAIR community is, well, this all seems to be outside the normal bounds of the practice of medicine and therapy. So why is it that, therapists and physicians who probably, really feel that there's concerns, and there was a question in there about, other members in WPATH, look, why aren't they speaking up and saying, hey, wait a second here. Obviously, there are some of us who are speaking up and giving space to forums to discuss. But why isn't it broader, the courage to speak up? I'm curious. Whoever would like to jump in and give their impression.
Well, I think there are a lot of disincentives for speaking up in our current state. People have lost their jobs and been attacked in terms of verbally attacked, and having their reputations attacked and things like that. So there is a lot of disincentive. However, there are a growing number of individuals, of physicians, and as well as LGBT individuals and transgender individuals who are speaking up about, wait a second, we need to slow this down and make sure that we are treating patients and, not fast tracking them, just addressing their needs. And so I think this does make things a lot better, because it's harder to oversimplify and say, oh, those people are all X, Y, or Z. But there's a broad array of very well-meaning, very thoughtful individuals who are speaking up. And I think a major change was when Dr. Laura Edwards Leeper and Dr. Erica Anderson wrote in the Washington Post about this topic. And I think that also made it easier for people who are clinicians to start speaking about this issue.
Mm-hmm.
I will. Yeah, I think public shaming has been probably the most, well, I think it is the most effective tool that we've used in civilization for thousands of years. And, yes, we have had punishments, but honestly, that's how society seems to operate, that if people are shamed, they do it less. And I think public shaming is a very, very heavy and very good control tool. And I think it has been used very heavily in this context. And I come from Catholic Ireland, so I grew up with shame. I know it well. And so I kind of recognize that there's a certain way of when I was a kid, let's say in very religious kind of world, they're killing you with kindness. And it's very hard to kick back against. It's very, very hard to hold your own and say, actually, no, I think I am kind, but I don't agree with your kind. My kind is long-term kind, your kind is short-term kind, or whatever. I think there are people starting to speak up. I think the crowd are watching the crowd. And I think there will come a time when there's a tipping point, and I think people will move over to our side, because they will realize that it is the side where there is kind of more integrity, because people are just trying to ask decent questions so that less people get harmed. Mm-hmm. And I think it's coming, and I think it's coming actually faster than most people think it is.
I agree. I think that people are starting to recognize that there is an entrenched ideological authoritarian movement on the both extreme sides of the issue. And I think what's happening is they're pushing people more and more towards the center, because there are lots of people who are sort of like, I think we should look at this more and we should understand this better. And then they're running into individuals in their communities who are like, we need to shut all this down, and there's no such thing as trans people. And so they're going, oh, and they're sort of walking away from that. Then you have people who are drifting a little bit more, say, to the far left. They're getting mixed in with that crowd, and they're basically saying, there's no such thing as biological sex, and we practically want hormones and vending machines on the streets. And they're going, oh, and they're drifting. So I think the majority of people are drifting. I think people started to drift out towards those towards the ends of the spectrums, and now they're just sort of coming back in, because once they got out, they were like, oh no, I don't think that, I don't believe that, it's too extreme, and it's our way or no way. And I like us more. I'd say there's probably about 80% of us that are in this middle space, and we don't all agree with each other. We all have different ideas about things. We're living our lives in different ways, but we are coming to the table, and we're coming to this space right now on this webinar to discuss these things, rather than me dictating to all of you how it's going to be from now on, and Lisa dictating and Carrie, everybody dictating. And that's kind of what's been happening. We're not authoritarians.
Yeah.
Yeah, and that kind of ties into, I think, again, a few questions in here. I would say, what do you all think the tipping point will be, which does relate to some comments and topical issues related to legislation in the states, right? So there's been different approaches of, well, like a total ban, or like going after, the way insurance is reimbursed, specifically Medicaid, because that supports a lot of the financing in a state, or, raising malpractice insurance premiums so high that, you can't, practice this, type of, basically trying to put the doctors out of business, so to speak. So yeah, I'm asking what would be the tipping point? And then also, like, is it going to be legislative? And what do you think about these legislative efforts? Because some people feel like there's no guardrails now. So it seems appealing to do legislative efforts, but then of course, as a physician, the last thing, is wanting obviously some, governmental body telling me how to practice medicine. So it's a tough issue. So I'm curious what the group thinks. So Lisa, you want to start off, or we can kind of go around?
Yeah. And I am by nature against politicians making medical policy. And I do think legislative bans are too extreme. We have to remember that some people are helped by transition and some people are harmed by transition. And if you go all the way to one end and say, and legislate bans, you're going to hurt some people. And if you go all the way to the other way and say that everybody who asks for transition should get it, you're going to hurt people. So, so I don't agree with either extreme. It's more of a middle, but what is going to be the tipping point? I don't know. I mean, I feel that one of the things that changes medical practice is lawsuits. Medical malpractice lawsuits. That I think changes medical practice, because I think gender clinicians are not seeing the poor outcomes from gender transition because those patients aren't coming back to see them. So I don't know. I mean, I'm hopeful that this will come from more people speaking openly and, as Zander said, sort of this middle ground of reasonable people who are trying to figure out how best can we help gender dysphoric youth and gender dysphoric teenagers. And I'm hoping it goes that way, but who knows? Carrie, what was the situation with the opioid crisis? Were there lawsuits that?
Yeah, that for me personally, I think that's the model. I feel that this will evolve similarly. I know there was the sort of conversation around like associations and the sort of bottom up versus top down. So for me, the opioid crisis was really a top down affair. A lot of the associations in the states, the folks that work in them, I mean, are well-meaning, but they're sort of managers of the regulations and bureaucracy. A lot of them don't actually see patients. So some of that ability to these things get into the hospital and clinical practice world from the top down in the states. And that's where the pain issue and the pain scale came from. And then there was a combination with Purdue Pharma, sort of the chicken and the egg, which came first or not is of debate, but that really was the starting point. There weren't people running around like my pain isn't controlled, but all of a sudden one day it was like, oh, well, we have to measure everyone's pain. And then that led to widening out the frame where all of a sudden these people were like getting exposed to narcotics, or there were surrogates for pain, maybe like depression and anxiety. So, and then just the horse was out of the barn, and now we're on the other side of it where we have this cohort of people who may no longer have access necessarily to the narcotics, so they went to street drugs, or, still people who are coping, but the lawsuits were the thing that brought it down. It unfortunately wasn't this large growing cohort of people who were overdosing and had passed away. It was attorneys general basically went the route of saying that all these folks that were affected by the drugs and overdosing on the street and buying and selling were a public nuisance. So they actually didn't go, so yeah, there's a little long-winded, but I do agree with you, Lisa. I think that that is probably where this is heading, at least in the States. We're much more litigious, and then, you know, so Stella, I would ask you, I mean, and I know Ireland's not part of the UK, but just that in the UK, where with the Tavistock clinic closing, and then this talk of lawsuits, I mean, do you feel that that is part of the tipping point? And then just, I know, again, you're not here in the States and legislative processes are different, and the healthcare system's different, but curious what you think about the legislative kind of frontier with ban.
Yeah, the word on the street seems to be lawsuits is going to be what changes this. I think public awareness will be also what changes it. I think there is a growing public awareness of detransition. I think 2 years ago, most people didn't even know really what it meant. And now I find I don't need to describe the concept the way I used to. I used to just, they'd stop, sorry, where are you? You know what I mean? So there's a public awareness that is growing. I think there's a medical war and there's a cultural war. And in many ways, if you separate them, you can get more clarity. So the medical war could be, you know, around puberty blockers, around easy access vending machine type hormones. And what I've noticed in Ireland, for example, the adult service never followed the WPATH model, very unusual quirk of Ireland. And there's an awful lot of talk of DIY, black market, online hormones. And I think that could be an indication of where things could go in the future. And I don't say that happily, I just could see that happening, that and that's why I'm not into legislation around medical care at all. My and Jen Speck's kind of theory is public awareness is the only way to go, because if you have public awareness of, you could transition, but you will have certain medical complications, and you might be happy, but you might not. If there's a nice rounded public awareness of that, just like they have eventually, I think, given public awareness around antidepressants and stuff. It took some time, but there's awareness of this idea that they're simply, you know, happy pills. That's kind of gone, I think. And so I think public awareness is where it's going. And I think we're getting there. Just, I do think everybody says the lawsuits. I wonder about that. I kind of think the media, I just think if we could just get some information out there, like with ordinary stories, all the stories about the happy trans people were matched with other more nuanced, more complicated stories, that would be enough. But I am told it's the lawsuits. So, but everybody tells me it's going to be difficult. I see Jackson and Bone have started they're kind of affiliated with Jen Speck, and they've started a legal agency to very much focus on gender issues. They only started a few weeks ago, and they're great. And I think, yeah, well, if this is the lawsuits, they're the women to do it.
Teva, what are your thoughts about the tipping point and the sort of the bans and the, you know, and then the misinformation, you know, legislation? There's just so much going on, legislation back and forth. Curious on your thoughts, and then we're gonna do some closing remarks after that.
I don't know what the tipping point will be. And I sometimes struggle to stay hopeful because I am in the social work world and we are very, very progressive. Out of all the therapists, we want to just go to the extreme. And so I don't see a middle in the social work field that's very visible anyway. And then with legislation, I agree. I don't like the idea of legislation getting involved more so in parental decisions. You know, I'm in California, so we're going the other way. We're not banning anything here. We are investigating parents who won't transition. And that really, really concerns me. So I don't agree with the legislation to all out ban, mainly because I don't agree with punishing parents for following what the clinicians have told them is best practice. I believe that most parents want the absolute best for their child. And we know in the field of psychology that separating parent and child, putting a child in foster care because the parents are accused of abuse for trying to help their child doesn't make any sense whatsoever. It hurts the child. So I'm totally against that. I'm also against California legislation making it so if parents don't affirm, if they don't transition, they're investigated for abuse and accused of abuse. And clinicians who might not affirm right away, they're also at risk for a board complaint of conversion therapy. So it's kind of grim here in California, and I struggle sometimes to stay hopeful, but these kinds of things, are helpful. So I think that we're slowly growing. And I do think that public awareness, I work with parents, and that's kind of like, I try to just focus my energy there. I'm here to serve parents because I believe that parents will best serve their children when they have the best information. So, yeah.
I'll just add really quickly that I think there's hope for social work as a social worker, of course. And the reason I think that is because I regularly do trainings for social workers through professional social work organizations, talking about working with trans clients in a culturally and linguistically appropriate way using the class standards. And when I talk to them, I take that very sort of middle of the road approach to, it's not conversion therapy and it's not affirmation therapy, it's exploratory therapy, which is in alignment with most of our intervention models and our theoretical orientations. And because of my efforts, I was awarded Social Worker of the Year in 2020. So there's got to be enough people within the social work field to be able to be recognized for the work that I do, specifically working with trans people as a trans person to get that award. So I'm holding out hope that, the loudest voices in our profession, the loudest voices in the trans community, the loudest voices on Twitter, the loudest voices that we're listening to, they are the minority. I think that's the truth. I think they're the minority. They're just the loudest and they're the most visible, but I don't think they speak for a majority of people.
I couldn't agree more. I completely agree with you. I think there's 5% very, very loud. There's an 80%, middle ground. And then there's a few other, people in other little groups.
Yeah.
Wow.
Yeah.
Oh, sorry, Zander. I was just going to say this has flown by with the Q&A, and I know we were just going to do, some closing comments. I think Zander was gonna take it from here.
I have one final question for each of you. So the question I have is, what do you consider to be the most important issue that people are not discussing on this topic? What do you consider to be the most important issue that people are not discussing on this topic? Who would like to start?
For me, I will start. Brave fool that I am. For me, maybe it's unusual that I think that the biggest issue is the silencing of the left choosing not to speak about it. They must know, there's certain newspapers, let's say New York Times or whatever, where they're writing a couple of fairly insipid articles, but they're really, I know how many people have written into them. I know how much information has been given, and they are choosing not to report. And I just think, where is their integrity? It doesn't make sense. I think there's been a silencing, a large scale silencing. And I think that's what keeps me up at night, because I can almost handle anything else except the suppression when people know there's information and their job is to distill and disseminate it, and they're sitting on it.
Yeah,
I think that's frightening.
Yeah, I agree. Lisa, Teva.
What I would say is detransitioners. I feel like a lot of these discussions happen, a lot of the, a lot of what we're seeing online. And I think that we need to talk about detransitioners and their experiences more, because one, they're people and they have these experiences. Two, this is going to inform everybody about the full array of outcomes. And we should all be curious about the full array of outcomes for any procedure. And so I think it needs to stay in that focus, and to be able to point out when people are being political in this arena.
Yeah, we on our last webinar, we had Grace Lindinsky come and talk as a detransitioner on the panel. So that was really wonderful. Teva.
I don't think we're talking enough as therapists about what is happening in the schools with gender identity theory and queer theory in the schools as being like the first point of entry for many of these kids to start to what I view as kind of like a disassociation between mind and body. And I'm confused as to why more therapists aren't speaking up about this, considering like in the field of trauma, it's well known that mind and body integration is a sign of psychological health. Yet the school children are being taught, hey, you can be a boy in the mind and a girl in the body, and it's no big deal. And it's just so flippant. And teachers are not gender clinicians. They are not mental health clinicians. And they're being assigned this role to explore gender with young children. And parents are not allowed to opt out, at least in my state. And the schools are allowing in like unscientific philosophy, and they're teaching it as fact to young children. And those of us who speak out, we are the bigots. And I'm just so confused why therapists who are in child development and teachers in child development, like they know that this is not appropriate.
Yeah.
But again, they're silenced. Yeah.
Well, that makes me think that maybe, Carrie, we should work on another webinar where Fair in Medicine and Fair in Education team up to really talk about this issue, because I think that is a really wonderful, that's something that we can do. I think that we have the people for that. I'll add my thing. What I think that people aren't talking enough about is that trans people are not a monolith. We are all very different. And so there's really, when somebody says gender affirming care, I haven't seen a good definition of even what that means, because I don't know how you could take one thing and apply it so far out. We're all very, very different, and just get to know us, specifically the adults in the community, to know that not all of us are in full agreement with how things are going, for example, in those schools, and the different ways that clinicians are working with their clients. But of course, clinical judgment is something that's, that there's wiggle room there, and our codes of ethics are broad and can be applied in so many ways that almost conflict with each other. So it's not as if we're being dictated like it's a law. Ethics aren't laws, right? And intervention models are not, statutes or ordinances. There is some flexibility with all of these things. So when you're working with trans people, when you're meeting trans people, we're all very, very different. And I think that's missing in a lot of the discussions. They're just calling us trans people.
Yeah.
Yeah.
Good for you.
Yeah. Thank you, everybody, for that final remark. And Carrie's going to take it back and talk us out.
Yeah. Oh gosh, so great. I just wanted to thank everyone again, because part of the solution, as was already mentioned, is talking about this, and also platforming people who will talk about it and have open discussions. And so certainly at FAIR, we're doing that. It's so important in lots of different aspects, but definitely in our healthcare aspect. So obviously, we love your continued support, signing up for our webinars. Obviously, you can donate to FAIR, but also all the panelists on here have, are associated with nonprofits that accept donations as well. So, please do look at those links and there's so much amazing work going on in this area. So please do that. And as Zander was talking about further ideas of how we can bring education to everyone, I already was talking with the education group today about doing a series, understanding gender ideology for parents in January or February. So we'll keep you posted on that. And I did want to say that, everybody can feel more empowered, that they're helping by attending these things, but also just, speaking up in the different forums, whether at school or if you're talking about clinical or hospital settings or associations, they really care what consumers think. And I think, to help us get over the hump in terms of being brave, just you can reach out to the patient experience people at hospitals, or just anonymously, through Fair Transparency, we have a portal where you could report things. But the hospitals and associations do care what people think. It's just that I think the silent majority is finding their way to express themselves. So, please, look into that and consider how you can speak out in other ways. And then just continue, supporting FAIR and folks, other ventures like Jen Speck and Lisa's great work. And then Teva's, involved with her clinical work. And Zander with his work. So I really just want to thank everybody, and we will see you at the next webinar, which is on the 27th about eugenics. So please sign up.
Whoa.
Okay.
Thank you.
Thanks.